Good afternoon, ladies and gentlemen. Let's imagine everybody inside this room have one missing tooth, just single tooth gap, no less, no more. According to research, 50% from all of you need bone augmentation right now. There's no written about the exception of dentists. We are also patients. Which material, which technique would you like to get inside your body as a patient? Will be artificial material coming from animals or chemical industry? Or would you prefer your own material, your own cells, antigens, your own immune system? Guess, what advices did I get when I started with augmentative surgeries? Come on, man, do GBR. That's the least invasive method. Okay, sounds cool. Why not to try it? Come on, man, forget on bone. Take care about soft tissues. That's the key. Sounds differently. Why not to try it? But wait for the best one. It should be done immediately, right now. That's super helpful for each patient who doesn't have the tooth anymore, right? Please, don't get me wrong. I fully respect GBR, soft tissue management, immediacy, and all other fields of dental implantology. It takes its place in recent dental implant treatment. There's no doubt about it. But there is no universal pill, no universal medicine solving all problems of missing tissues in dental implant treatment. And that's the beauty of our job. Agree? Ladies and gentlemen, please fasten your seatbelts. There's not going to be a romantic story today. My name is Dr. Maroš Kopacka. I came from Slovakia, Europe, and today I'd like to show you how does the most of my patients look like. And they look exactly like this. What do you think? Disaster, right? There is thin crest, there are missing teeth, already healed crest, so no chance to place implant immediately. There is thin biotype. There is shallow or even no vestibule. There is also muscle pull from the cheek. Everything's wrong. When we took x-rays, there is no doubt about it, we need to think about doing something with bone volume there. In 2/3 of the crest, we need to do something with it. So it's time to start to think about bone augmentation. Please look at this picture. There are two different worlds, two different places close to each other. One, the place which is very poor in bone, and second one on the other side, very close to it, which is very rich in bone. Actually, that's the most important, most attractive harvesting sites from all intraoral harvesting sites at all for intraoral bone augmentations. It's called retromolar area. I always like autogenous augmentations because it gives me feeling like Robin Hood. Still the same story. Taken from the rich and given to the poor. Again and again and again. We'll grow again. So, let's describe our playground. That's retromolar area or external oblique line, as I mentioned. No worries, there are very few rules we have to keep to stay on safe side. First of all, we have to project the occlusal plane to the anterior border of the ramus, and that's the most distal point of our preparation. From that point, we go deep down perpendicularly to the occlusal plane, and that's the border between mandibular body and mandibular ramus. We don't want to cross that line, cross that border. Otherwise, we go closer to the nerve, inferior oval nerve and both vessels. We don't want to injure them, of course. Then we have to keep free of preparation at least 5 mm from the base of mandible and from the mental foramen. The rest is created by convexity of anatomical structure. It's balconel-like structure, external oblique line. It's not a secret, I love piezo. I use one straight and two curved piezo tips, surgical hammer, and surgical chisel. That's it. Let's show it clinically. So I usually start with horizontal crestal bone cut with straight piezo tip, no pressure and sufficient coolant. Then I continue with distal vertical bone cut with angled piezo tip, again sufficient coolant and no pressure. And now comes the time to slow down, to think and to measure. We created also the most distal border which shouldn't be crossed, and from that point we can enlarge our preparation mesially till we want, till we need. It's very easy to scrub the whole case by harvesting a tiny bit smaller bone block than we really need. It happened to me. It's not a secret. So after we have to harvest at least 20% bigger bone block than we really need to avoid it. So after estimation, proper dimensions of future bone block, we can continue with preparation. We're closing the preparation with mesial vertical bone cut with angled piezo tip, with sufficient coolant and no pressure. And then horizontal apical bone cut. Again, angled piezo tip, no pressure and coolant. Now we got predetermined fraction lines. So now comes the time to bring a little bit more drama into the operatory. And it's time to take our hammer and with few energetic hits on the chisel, we can break the rest of connection between mandibular body and the bone block. That's the way how we got the situation. Look at this, please. Now I'm going to ask you very few questions. Is there open sponges bone? Come on, wake up. No. So please don't try to ask me about invasivity of this procedure. It's optimal invasive. Is it painful? No, it's not. The whole procedure was done under infiltration anesthesia, and even after the procedure, patient doesn't have any pain. Why? It's not a secret. We all know it. Cortical bone doesn't have any sensitive nerves. Will be missing there the bone volume? No, will not. It will rise again exactly like a grass on your backyard. So, isn't it beautiful? I found it. Here is everything what we really need for the whole case, for the whole bone augmentation. We don't need membranes, we don't need pins, we don't need antibiotics or mixing with antibiotics. We need just this one bone block, no more. Because it's quite thick, it's time to split it, to thin it. I use for that step diamond-coated disc, very thin and very flexible, with sufficient coolant. And in that way, we got these two beautiful bone plates. These bone plates are even next source of our future gold, future bone chips. So we can thin them even out with bone scraper and collect all bone chips, all gold inside bone scraper. Immediately after it, they go inside the bowel, surgical bowel, under sterile saline solution to protect them against drying out. After giving a proper shape to our bone plate, we have to fix it. We have to create some stable situation. It has to be stable. We don't want a resorption. So it's time to fix it. I use for that step 1 millimeter screws in diameter, in different lengths, of course. And we create container, just a frame. Please look at this picture. Now I'm going to ask you again. What's the most important here? Is it the residual bone? No. Micro screws? No. The bone plate? No. It is the space in between, because that space will change into new baby bone even after 4 months. Because that space has to be filled up with all collected bone chips. Then we need, of course, some hermetical closure, tension-free closure. I use for that step double-layered closure, as our colleague and friend mentioned already. First layer done with horizontal mattress sutures, then single interrupted sutures over it to get contact surface to surface. And we all know, it's not surprising for you, every single bone augmentation destroys vestibule. No doubt about it. So my next step is creating new vestibule, together, done simultaneously with implants placement. So we can see here no sign of vestibule. And I continue with Kazengenplasty. Kazengenplasty means doing it means separation, non-keratinized mucosa from muscles underneath. Then cutting all muscle fibers away from the periosteum. And of course, we don't need more that screws, micro screws. Okay, ladies and gentlemen, I'd like to introduce you new baby bone, just in 4 months. It was not an issue to pre-drill 3 holes for 3 implants. I used Megagen enriched implants, and then I sutured periosteum to periosteum at the top of the crest, and non-keratinized mucosa to periosteum deep down in new vestibule. The healing was super fast. Even after 2 weeks, we got this beautiful result. So we have now bone, we have implants, we have attached mucosa, we have vestibule. And what's missing here? I drive Porsche, I don't drive Vespa. I'm not satisfied with the result. We need keratinized tissue. So again, Robin Hood style, I stole a piece of tissue from the heart plate. I modified it with vertical cuts. It allowed me to stretch it from the canine to wisdom tooth. And I sutured it to the naked periosteum, got rid of muscles with modified horizontal mattress sutures according to Professor Gluckman. And here's the result just after 2 weeks of initial healing. This is the result after maturation of soft tissues. So we have now bone, we have implants, we have attached mucosa, we have keratinization, we have sufficient height and width of the soft tissues. So we can continue with prosthetic phase. In prosthetic phase, I chose 3 multi-unit abutments. I placed over them scan bodies. This is X-ray fit and check. Took a scan, we sent all data to the lab, and they produced the bridge, and in between was patient wearing this protective caps. So here is full zirconia bridge coming from the lab, and the bridge was fixed to multi-unit abutments then. So, ladies and gentlemen, now prosthetic and surgical phase is over, and I'm going to ask you something with what we began. Would you rather sell pieces of animals in bone substitutes, membranes, or would you rather sell your skills, your experience, your knowledge? It's up to you, you decide. But I'd like to encourage you, this is the most forgiving technique at all. You can start, even on Monday, with the same or even better results than here. Thank you for having me here, but I'd like to mention one more thing. The most important thing is not to take apart, it is to win, of course. That's the reason why we are here. But I already won. I already won this beautiful wife sitting over there and this amazing princess. Thank you, honey.